So hopefully if you're not sick of me already after the financial talk, we have nothing going on in the wait list, so we'll fly right through this and get into lunch quickly, right? As mentioned earlier, I am on the OPTN UNOS Board of Directors. I did just cycle in this past July, so certainly after the heart allocation changes had come into place. And again, the administrator hat that I wear, makes me think about how do we navigate the current system? How do we think about things in the future? And again, I can't go back enough to talk about having some engagement. So very quickly, here's the objectives. We'll kind of take a look at, where we got to where we are today, and I'll kind of fly through them pretty quickly, because I think there's enough folks in the room that live it day to day that they certainly don't need my explanation of how we got to where we are. But in the previous model, right, so there was 3 statuses. And I will tell you that I had an uncle on the heart transplant list in Virginia who was a status 2, and he died waiting. And I remember when, his wife called me up and said, Uncle Rich is going on the list, and, he needs to get a transplant, and I'm the family expert on transplants for some reason. And I said, well, what status is he? And she goes, well, what do you mean? And I said, find out what status he is. And she came back to me and said, he's a status 2. And I said, he'll never get a transplant. And sure enough, he died waiting. So, again, this is very meaningful to me on an emotional level, what we do and the patients that we serve. I think, the next slide that talks about the why gets to some of that a little bit. There are definitely some exceptions for some candidates, and I think later in the talk, if I forget to bring up the exception conversation, call me out on that, and we'll have some dialogue around that. Obviously, there was biological matching. That'll never change. Distance from donor hospital, and then, of course, wait time is a tiebreaker. So in the current model that came into play in October of last year, right, so now there's 6 statuses. And really the reason behind that was to make room for technology and the folks that are in this room. So implantables, like where do the VAD patients, where do the total artificial heart patients fall in the 1A, 1B, 2 category? Well, they didn't really, right? So a big push for a different system was to exactly recognize the work that we're doing that's moving forward, and that'll never stop either, right? And that's that more specific criteria to qualify. There also is part of the final rule about removing geographic boundaries to access. So how do we allocate this, what has been determined to be a national resource, to the sickest patients, right? And what didn't change is obviously for our pediatric colleagues and the medical matching, right? So, blood group is always gonna, be part of our world. And so this is what I talked about. Why did we need to do it? Well, for technology, to also gain a better understanding of how patients do on devices, right? So outcomes. Better understanding of what the candidate risk is without a transplant. And you'll see a slide where I share what is sort of being talked about at the regional meetings around candidate risk. And ultimately with the goal to reduce some deaths on the wait list, right? So ultimately what I think we are charged with doing is saving as many lives as possible. And I think that, that is the guiding principle at the UNOS OPTN level. And I think it's really the reason why we all got into this work, is to save as many lives as possible. So I think the takeaways in the new allocation is that, again, it better stratifies medical urgency cases. ECMO patients are being given top priority. VADs and other are seen as viable long-term alternatives to transplant. And again, I want to share what the word on the street is about that. The principles guiding geographic organ distribution are also changing. Again, the final rule about removing geographic boundaries. And that all new policies will always be part of evaluation, right? Like it's never going to be sort of the crock-pot model, what I say, set it and forget it, right? We're always going to have data. The data will never stop. And I think it certainly is our obligation to look at the data and not only make some determinations about what it's telling us with these changes, but also how we think about patients at our centers. So the first report to come out from the OPTN was a 4-month post-implementation evaluation, and the early monitoring suggests that they have resulted in broader sharing. And I want to say, you know, take sort of your emotions out of this. You know, well, my center lost organs and somebody's getting more. Take it just sort of for face value. There is broader sharing with a decline in local shares and an increase in, again, more regional and national. Whether you think that's a good thing or not, just kind of keep that in check for a minute or two. Hearts are traveling greater distances, right? There's been no impact to the number of waitlist registrations, transplants performed, or heart utilization. And while some centers have seen a decrease in the volume, it appears that the waitlist composition may explain this, right? So this is what we're hearing. You know, I went to the Region 8 meeting, which is outside of my region. It was in Kansas City. And there was a breakout session about the early outcomes. And what I heard in that room, I literally typed. I had my laptop up and I kind of was, you know, like a court reporter. I typed everything that people were saying. And what I heard was people were saying that the early reports are not a surprise, right? That what they're seeing with the sharing, some centers are seeing an increase in volume, some are seeing less, not a surprise. Allocation is changing medical practice. And this is very concerning. This is what I heard. They go, people are changing what they're doing to get people on the list, right? It wasn't said, but it was implied that are we managing patients pre-transplant for status on the list as opposed to post-transplant outcomes? Because people felt it. I think some centers were doing it. And all of that is extremely concerning. Centers are moving away from a durable to a balloon. And this is what I referenced just a second ago, that VADs are not comparable to transplant, right? So we can't just plug in different words and say that how we decide allocation is a better way to do it, right? Cost is increasing. Where is the cost increasing? We're flying to get organs. Dr. Skipper told me a story last night after dinner. You know, he had a team do a dry run, right? Ran out, had every intention on coming back with a viable organ, spent an entire day parked somewhere, came back empty-handed. Somebody has to pay for that, right? I can't ask my teams to do that pro bono for me, you know? So this comes at a cost. It comes at an actual cost of hiring pilots and airplanes, but it also comes at a cost to our teams, the fatigue. I think there's an emotional component of how much the teams are flying back out and come back empty-handed. I mean, we want to come back and do transplants. That's what we want to do, right? But there's actual costs as well. And that the outcomes data isn't really yet available. Again, we talked about, you know, pilot availability. There's a lot of logistics, you know, what teams are going out. What I heard at the regional meeting a few months ago is that the one-year data will probably be available towards the end of the first quarter in 2020, right? And you all know the reason for that, right? So we all fill out tie-dye forms. These are these forms that you have to fill out on transplant recipients. There's like a 90-day compliance, right? So when do coordinators have time to do it? Around day 89, right? You know, sometimes because the information is still pouring in. We're not going to fill out a form on day 5 because they're probably still inpatient. We don't have all the data to complete the forms. But some of it is operational, right? Like our teams don't have time to sit around all day filling out, you know, compliance forms. And so when you think about the one-year data and then you add 90 days onto that, it's October plus 90 days puts us into early of next year and then some time for analysis. So the 1 year post-implementation is probably not going to be out until, again, I would think at the soonest end of February, maybe March. But I think realistically, given some of the publications that are now starting to emerge in our community, UNOS may even take just a little bit more time to do their due diligence of looking at the data. So An analysis of the registrations, and again, this is something that Syncardia has done. I haven't done it. This is, this is certainly not for me to speak on behalf of the OPTN. But when you look at data, right, and it's publicly available, and you can even request private data, from the time of the allocation change through the end of August last year, they took a look at what's going on with the removals and the wait times under the new guidelines, right? So think about it. So, as Mike said to me, it's sort of clean data if you think about it, because it's from the time the allocation happened. Regardless of who those patients were on the list and how they kind of got rejiggered into new status, these are people that, as of October 18, moving forward, have just been part of the new allocation. And there's been an increase in wait time for the Stat 1 and 2 patients associated with removals and too sick for transplant. And there's a graph that I want to show you coming up next, or 2 slides. And just over 7% of the Stat 1s and 2s that have been listed have either died or been removed for being too sick. So I think that, as a program, we need to challenge ourselves and say, is that an acceptable statistic? Are we willing to allow greater than 7% of our sickest patients to die waiting? And that nearly half of the patients initially listed as a status 4 are still waiting. And again, you'll see some actual numbers on what the wait time is. And you'll see, again, in the next slide, that those status 4 patients, who they become. So let's jump right into it, right? So here's the numbers, and Mike, I'll ask you to chime in if I kind of get off the rails a little bit. But so again, UNOS registrations from the time of the allocation change through the end of August, as of recently, right? So there were 142 that were put on the list as status 1s. Of the 142, 116 of them were transplanted in about 10 days, right? 18 of them have gone on to be too sick or died at time of removal about 24 days. The statutes tell a similar story, right? So of the 608 that were added to the list, 523 of them got transplanted within about 14 days. And 39 of them, at around day 40, were removed for either dying or being too sick. So jumping ahead to the Stat 4s, right? So there's over 1,300 of them that were added to the list. 625 of them, so 45+%, did get a transplant, but they got it at around day 73. 67 of those Stat 4s, or close to 5% again, have gone on to die or become too sick with an average wait time of about 118 or 120 days, if you will. And I think in the next slide, I'm going to ask you to think about your programs and who you think that population is. Right? Because could they potentially be transplantable patients? But one of the things Catherine and I really kind of chewed on, thought a lot about, and from an operational perspective. So let me go back up to the first statistic, right? The 116 patients that got transplanted in 10 days. And the ones that went on to something else is happening with them, right? And we'll talk a little bit about outcomes, and I'm not, again, clinical, and so I'm not here to sort of script that to you. But I think it begs the question that if we know that the average wait time is about 10 days from when a patient as a status 1 will get their ultimate transplant, what are we doing around day 6, right? And what this really is around is about day 7 or 8, you're going to know if you're getting offers, right? Because the offers come, at least a day or 2 before you actually procure. And so at around day 6 or 7, are you guys thinking, uh-oh, I may not get an offer from my patient. What is the outcome? And I think the outcome could be too sick or they die. It could be that for 2 of them, they are still waiting. Or could this be, again, a discussion that you have in your centers about total artificial heart? And when would be the right time to think about that for these patients, right? And how do you medically manage them? Because I think my greatest takeaway as a non-clinical administrator is, again, you need to back the conversation up before the event actually happens. So before the average wait time happens of 10 days, what is the plan, right? And if I've said it once, I've said it probably 100 times in the past couple of months. What is your plan for these patients, right? Because we've heard all morning, and we will continue to hear all day today about those very difficult patients and how we struggle with making clinical decisions for them. But I think that this information certainly is compelling to make you think that in the new world, it's different than it was a year ago. And how are our teams changing to meet the patient needs today? So I'm going to drop down to the bottom slide, right? And in the last one, or not the bottom part of the slide, I should say. In the last slide, I mentioned about the status 4s and needing to move up. So right here is where I'm at, right? So these folks who were stat 4s at the time of listing became 1, 2s, and 3s by the time they were transplanted. So again, it goes back to the regional feeling about managing patients for status on the list. Is that what centers are doing? Because I think there were a lot of centers that, quite frankly, when the switch happened, their entire list became status 4s and they weren't getting any offers. And they had to start to think, well, gosh, what do I need to do to start getting offers from my patients? Of course, with outcomes and all of these headwinds that we are asked to balance every day when we make decisions. But I think that status 4 is very interesting, if nothing else, to sort of show that exactly what people are worried about is kind of happening. I think if I were to say it differently, again, I think the sickest patients are getting the organs. But what does that mean for the patients who a year ago were getting organs and now are waiting greater than 200 plus days?
Yeah, and Kim, the other thing, if you think back to the economic model where we showed in the bridge procedure, the TAH is negative, but the ECMO procedure and the BIVATA is positive from a reimbursement versus cost. If you were to plug the 24 days and 40 days length of stay into that model, those procedures would all go negative to about the same extent. So there's definite correlation.
Yeah. Thank you, Mike. So who are the diagnosis at time of listing? And I'm going to leave this slide up here a little bit for the people way smarter than me in the room. What we talked about is, who are the type of patients that we think could benefit from total artificial heart, right? And so when you think about who your patient population is, and then you kind of move your eyes over to the too sick or have died, is there a significant number of patients in a particular pool, or maybe groups of pools, that could benefit, right? And so knowing that the stat 1s and 2s, or the 4s that move into a 1, 2, or 3, are the ones that are ultimately getting the organs allocated to them. Who are these folks in the they become too sick? Can we keep them out of that grouping? So I mentioned it, I think, in my earlier slide, that the OPTN has approved a continuous distribution model. And this is where I'm going to read from my notes a little bit, just because I don't want to get it wrong, and I hate to do it, so I apologize in advance. But The continuous distribution would in the future replace fixed geographic boundaries, and what they're looking to do, and of course this will take a lot of work in committees. Again, I encourage you to take an active role in having a voice in some of those conversations, is that they would receive a relative distribution score. And so current state looks like above the line, right? Each one of those buckets gets an equal weight, right? But in the future, maybe how sick a patient is will actually get weighted higher than things like outcomes. Maybe, right? And I'll preface this by saying that as a transplant community, we can't even decide how we define those buckets. So this is absolutely an opportunity for you to have a voice in some of these things and talk about, what about patient access? If I'm a single center in the state, how available is it for patients to even get referred to me and then come in for transplant? Should things like medical urgency outweigh outcomes, right? Let's have some very good debate and dialogue around what we think is best for our patients. And so the bottom, although being a charge, and there was an opinion paper that came out in the lung committee, you can look it up on the OPTN website, and it really talks about this. And if I didn't say it before, I literally just came from the UNOS Board of Directors meeting in Dallas. It was Monday, Tuesday, and Wednesday of this week. And where they're looking to go with this, obviously in lungs first, because they're the first one to put the op-ed paper out on it. And it's just an opinion paper. It certainly is not policy yet. But the charge is to roll it out amongst all organs. And I actually sent to Catherine, I think on Tuesday, I said, look at where they're slating heart to move into this direction. And it's one of the last organs. And the rationale that was shared in the room was, well, heart just went through a major system overhaul, so let's give it a little more time before we kind of, rejigger the system again, if you will. I have an opinion about that. I welcome my colleagues in the room to share their opinion about that. But I think one of the biggest takeaways, the more I just kind of slept on it, is, these are very complicated questions, right? Everybody who wants a life-saving organ is not going to get one. I mean, that's the reality in our world. But how we define policy about who will in the future is very important. And I think where we are as a community is very far from where we've been 20 years ago. And we're probably not there yet, right? So I think there's still more work that can be done to make it a little bit better. And I don't know what that is, so don't ask me. But I think that, we need to continue to challenge ourselves with medical advancements, with access to care, with all of these challenges in the financial world, to really make sure that we do create as much of a system in this country where people who do want them can get them. But I just don't think we're there yet. So there was a paper that came out 2 weeks ago. This is it. Quick show of hands in the room. How many folks are familiar with this? All right, so if not everybody, almost everybody. So it's important to recognize that the authors are very well respected in this community, and certainly the information that they have provided is very valuable, right? But they also caution, and I'll sort of summarize their abstract, if you will, is that, even in spite of their opinion and their analysis of the early results of this, that really they want people to continue to be talking, right? That this is very much an ongoing conversation. And so to that point, and again, I'm going to go back to reading from my slides a little bit. At the Board of Directors meeting, I asked UNOS, I said, what's your take on this early outcomes paper that has been produced? And so I'm going to read to you a little bit about what they shared. So they said, the primary focus of the heart allocation policy modifications implemented in October was to better stratify the heart candidates on their waitlist mortality. And so they're optimistic regarding the potential reductions in waitlist mortality, right? At the same time, the data needed to analyze the outcomes is still being collected. And I talked about that, right? So there's a reason why the 1-year post-allocation data isn't going to be available on October 19th of 2019. It's because there's a delay in the reporting. Sometimes there's, changes that happen. But again, there's a reason for it. According to UNOS, the Thoracic Committee is acutely aware of the importance of providing accurate and timely monitoring reports to the community. And so there is a 4-month monitoring report on the OPTN website, and I'm sure if I were to ask the question how many people saw the OPTN 4-month report, I'd probably get the same amount of hands raised, right? This is what we live and breathe every minute of every day, is what's going on, right? So the Heart Subcommittee is continually working to improve the system. For example, the subcommittee is currently reviewing the use of exceptions with the intention of providing the thoracic community with guidance document addressing the candidates at status 2, okay? The OPTN data is a public resource, and I think this is important. The OPTN data is a public resource, and it's made available to everyone. So for example, the UNOS releases quarterly STAR update files. And at the same time, the OPTN will not likely be the first one to put something like this out, right? Instead, their intent is to perform thoughtful and thorough analysis of any policy changes. So I think it's sort of UNOS's position of, they have to do their due diligence. They have to make sure that the data comes in is valid, although it does become publicly available for, folks like our colleagues to be able to, make this analysis. UNOS is doing their due diligence in their own right, and I think we have to sort of respect that, okay? The OPTN recognizes that there's value in attempting to identify early signals, and so for that, they really thank the authors of this article, and certainly, UNOS wants to be a partner in this. They don't want to create policy that, again, is that crockpot model of set it and forget it. I mean, they're very aware and want to be mindful and respectful of changes that are happening medically like we're seeing. So this is where I'm going to turn it over and sort of get your take on this and help educate me about what you guys are doing at your centers to address this. And I certainly don't want to steal the thunder of, of Dr. Skipper, because I know he's going to be talking about some of the experience at his center. But I think it would be great for us to all share that now that we are in the current world, I don't want to say the new world, but in the new world, how are centers dealing with this? And again, Catherine, maybe I'll even ask you to kind of tee up a little bit about where the place of total artificial heart sort of fits in as we hear some of the feedback from our colleagues.
I think it's more important for the physicians to
Thank you.
to chime in.
Of course, of course. Nobody's brave?
All right. I could talk all day about this. We'd have a whole conference about this. I know the authors in that paper. I'm aware of it, and I've read it. I'm in a big transplant center. We are struggling with the allocation system. We're competitive in status 2. It seems like status 1 is that kind of, everybody gets nervous when you go to status 1. If you look at your stats there, too, you showed up there, there's a high percentage that were withdrawn out of there. If you look at those stats, and to ask yourself, the way we see status 1, and I've toyed with status 1 recently, okay, and I get offers immediately, which is good. I mean, it's good for the patients, but I'm selective. And this ECMO business, just my 2 cents. I mean, you know, I'm going to use I know Shelley Hall too. I talked to her about this too. You know, in a way, in status one, I don't want to use the word. I guess I'm going to use it. Gaming the system.
Yeah.
So why should I put a Impella 5.0 or that new 5.5 that's coming? I want to just put ECMO for a few days and then go back, you know, until we're skipping. So at least in my humble opinion, it is creating the status one is not like a 1A. So if you go to status one, you're going to get an offer. You're going to do it, which is good. And I see your point about, you know, patients that are more urgent. However, also there's a lot of ethical discussions too. If you're trying to transplant patients off ECMO when you could give it to you see what I'm saying? And the last question I have, and I'll open it to the audience too, is where do these mechanical support patients fall? Because some would say around the country that the LVAD patients are getting the shaft. And tell me a little more about where the TAHs would fall on this classification system. That's all I got to say. Thank you.
I don't have answers for Dr. Bruckner, but I just want to share my one comment is I have a presentation in the breakout period with details about what our program is doing, but I think the one thing I do like about the new system and how it affected our region is it puts stewardship on the providers to decide which patients are ready for transplantation. And we felt helpless in the previous allocation model where I could look every blood type O that was taller than 5'6" in the eye and say, you're going to need to have an LVAD. I know you're seeing me here in clinic, but you're going to have an MCS device. You will never get transplanted unless you do that. And now it's helping us. Now, so I think the onus is on all of us in the room to figure out, okay, I have this architecture to within which I need to work and make sure I find the right pathway for my patient to get to whatever endpoint they need so they can live, and either with a transplant or with a device. So I do appreciate that. Now, I think this early data is showing a little bit of how people are trying to recalibrate to the system. And, you know, we're all kind of dabbling, putting our toe in the water, trying to figure out how to do this. But in general, I think there's been a sense of relief, at least on the East Coast and especially in my state.
I'll just go to the whole system is again getting to transplant, decreasing waitlist mortality. That is not the goal. UNOS is in the business of doing transplants, so the system is built to get to transplant. And I know it's not like an evil thing, but that's the true statement. That's what UNOS is transplant based, but we're patient based, right? And so getting to a transplant on ECMO and getting 81% of ECMO patients to transplant, I think is not a win. Because I'm just telling you, I bet the results are going to show that those ECMO patients don't do as well. So if you look at the community as a whole, the amount of years post-transplant survival for the entire community will go down. Because again, getting to transplant, not the goal. So I think that's the problem.
But David, I think people agree transplant survival is very important. We're held to the metric, sometimes to a fault.
Yep.
But what we should be doing as providers is recognizing that the survival is not going to be as good as ECMO. And the onus is on us to decide not to do it.
But the system, yes, I 100% guarantee. Agree. But it is what it is, and you see how human behavior is, right? Human behavior is towards that, and that's because of the system that's being built. So I'm just saying, just to be honest, I have a grant too. What we really should be doing is best matching. So we have the data. There is big data out there. It exists. Right, we have data, but what are the best matches? So this patient who is a very good donor, right, if he goes to the ECMO patient, it doesn't change the ECMO patient's survival, whether he's a good donor, a bad donor, or middle donor. But that's where that good donor goes. However, if that good donor went to this patient, right, who is a very good recipient candidate, his survival increases 30%. We have that data. That data exists. Right? So if we can figure out the best matching, that will be best for the community in total and more years survival, I believe.
Yeah, thank you for that. I think we'll just maybe add one more comment just to kind of keep the schedule as close to on time as we can. Thank you.
I think there was something that you said very early in your presentation that's actually really, really important, which was there is a change in medical practice which is concerning.
Yeah.
And I think that's it. That's the crux of this. We have gone back 15 to 20 years in medical practice where dual inotropes and balloon pumps are now once again acceptable therapy. And what we learned very early in the continuous flow LVAD era was that that's not a good idea. And we should put durable devices in them, resuscitate the patients with an LVAD or a TAH, it doesn't matter. Resuscitate the patients, make them more suitable and better candidates and recipients for that transplant. Transplant is not the end. I agree with David completely. I think that line too, that's the only thing about this that we should really be talking about. We have changed medical practice on the basis of a policy, not on the basis of patient outcomes or anything else.
Yeah. Thank you for
Why
that.
don't we even have the UNOS? We have UNOS because Starzl was getting $50,000 for doing kidney transplants on Arabs in Pittsburgh. And finally, the lady from Pennsylvania complained about it, and they looked into it, and they decided that somebody had to regulate this thing. So that's how UNOS began. I was the co-chairman with Phil Oyer of the first committee. We spent a year, we had no cardiologists on it. We spent 1 year deciding how to allocate the organ. This was in 88, I think, 87 or 88. So we'd been doing transplants for over 5 years. And we decided there would be 3 categories. Status 1, if you were in the ICU. Status 2, if you were in the hospital, but not in the ICU. And status 3, if you were an outpatient. And the tiebreaker would be days on the waiting list. Well, that seemed to work pretty well until the cardiologists started complaining that, and their complaint was actually the LVADs were automatically a status 1, but there were very few hospitals had LVADs, and I was chairman of the UNOS chest thoracic committee for 3 occasions. And I will tell you that I've wasted a lot of time doing things in my life, but that's the most wasted time I've ever spent was on that goddamn UNOS committee. Amen. And it has just gotten more and more convoluted, more and more complicated, that we have this idiotic list that you've got to have something on your telephone, a computer, to figure out who the hell is next. And also, we've got 147 hospitals in America approved to do heart transplants. It's ridiculous. They have 5 in Great Britain, about as many in Germany, and anyway, it's just gotten out of hand. We should have never had it in the first place. And if Starzl were still around, I'd really bitch and moan. I did while he was alive. I always complained about it. He just laughed it off, you know. He was getting 50 grand from those Arabs. He didn't care. Anyway, you ought to do something about it, but I don't know what the hell you could do now. It's just like the IRS. I think it's beyond control.
Well, I just want to thank you all for allowing me to give a second talk today. And again, I appreciate that you want to listen to what I have to say. So thank you all very much.